welcome everybody. My name is Brandon Bergman. I am the Associate Director at the Recovery Research Institute here in Boston, Massachusetts. And we're thrilled today, as part of our Opioid Response Network set of presentations, to have Dr. Amy Yule presenting on prevention and treatment of substance use disorders in youth with psychiatric disorders. We're going to just start off before Dr. Yule presents. Just have a few introductory slides for you about the Opioid Response Network. Zoe, am I sharing my slides okay? Can you see them? Great.
Yes.
Awesome. All right. So the SAMHSA-funded Opioid Response Network assists states, tribes, organizations, and individuals by providing the resources and technical assistance they need locally to address the opioid crisis and stimulant use. Technical assistance is available to support the evidence-based prevention, treatment, and recovery from substance use disorders and stimulant use disorders. The Opioid Response Network provides local experienced consultants in prevention, treatment, and recovery to communities and organizations to help address this opioid crisis and stimulant use. The ORN, the Opioid Response Network, accepts requests for education and training. Each state or territory has a designated team led by a regional technology transfer specialist, or TTS, who is an expert in implementing evidence-based practices. If you have any questions or to submit a technical assistance request, please visit www.opioidresponsenetwork.org or email orn@AAAP.org, orn@AAAP.org. And just a couple of more notes. Funding for this initiative was made possible in part by this grant, as you can see here, from SAMHSA. The views expressed in written conference materials or publications done by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. So what's the approach of the ORN? It's to build on existing efforts, enhance, refine, and fill in gaps when needed while avoiding duplication and not recreating the wheel. To provide training and technical assistance via local experts to enhance prevention, treatment, especially for medications like buprenorphine, naltrexone, and methadone, and recovery efforts across the country addressing state and local specific needs. And as part of our series at the Recovery Research Institute, our series of ORN presentations, I just want to give you a snapshot of all the different kinds of presentations. We've had 19 so far. Today will be our 20th, and we're really thrilled to have Dr. Yule here with us. Before I introduce Dr. Yule, just one final note. Our next presentation, make a note, will be on April 22nd of 2026 with Dr. Sam Mizell of Boston University. He'll be talking about caregiver involvement in adolescent substance use treatment core principles and applied techniques. An email and notifications about registration will be coming soon. Everybody who is here today, you'll get an email about registering for that webinar. So with that, I'm going to stop sharing and introduce. I'm going to stop sharing. There we go. And introduce our speaker. Can you still hear me? Great. Dr. Amy Yule is the Vice Chair of Addiction Psychiatry at Boston Medical Center and an Associate Professor of Psychiatry at the Chobanian and Avedisian School of Medicine at Boston University. Her research is focused on examining interventions to prevent substance use disorders in youth with psychiatric disorders and reduce harm associated with substance use. She is also focused on evaluating treatments for individuals with co-occurring psychiatric and substance use disorders, including medication for youth with bipolar disorder, community-based treatment for youth with psychosis, and insurance-based time-limited care management programs. Her clinical practice is within the Catalyst Clinic, which serves youth with substance use disorders and co-occurring psychiatric disorders, as well as their family in a multidisciplinary primary care-based clinic at Boston Medical Center. So with that, let's welcome Dr. Amy Yule.
Thank you, Brandon, and thank you to the ORN and the Recovery Research Institute for the opportunity to be here. And so before I get started in talking about the prevention and treatment of substance use disorders in youth with psychiatric disorders, I want to note that I don't have any ACCME defined conflicts of interest to disclose, And then I will be talking about off-label use of medication as part of this presentation. And then as I view things, Brandon and Zoe, you guys disappeared a little bit. And so just again, please speak up if there's urgent questions that come up as we're going through this content.
Will do.
So today, as we talk about prevention and treatment of substance use disorders in youth with psychiatric disorders, we're going to try to cover three key points. One is thinking about why it's important to focus on substance use prevention and treatment efforts when we're thinking about youth with psychiatric disorders. Two, we're going to also talk about adverse effects associated with opiate and other substance use in youth and strategies to decrease risk. And then three, we'll be talking about medication treatment for youth with a psychiatric disorder in the context of a co-occurring substance use disorder. So to start with, I do often like to kind of ground us all in thinking about some of the kind of national epidemiologic data and looking at the prevalence of substance use and substance use disorders, both in youth without a co-occurring psychiatric disorder and youth with a psychiatric disorder. And so when we look at data from national surveys, this is a kind of a figure showing you lifetime illicit drug use by grade from Monitoring the Future, which is an annual survey that's done with high school students. And you see that kind of on the below, it shows you kind of a wide range of dates. So this is looking at patterns between 1969 and 2023. And it's, lifetime use by grade, but these are 12th graders reporting on when they first started using substances, also at which grade. And so you can see this overall kind of downward trend. And so I think that that's one positive to be thinking about, is that overall we have seen a downward trend across all different substances for adolescents. So again, that's positive. But still, 37% of 12th graders did endorse lifetime illicit drug use. That's largely cannabis use. And so as we do think about substance use, what do you want to make the important distinction that substance use does not mean a substance use disorder. And so as we're going through this talk, we will be at times talking about substance use and then at different times talking about a substance use disorder. And I want to just remind people that a substance use disorder is a diagnosis that's made using DSM-5 criteria. And it's really, when we make the diagnosis of a substance use disorder, we're really looking at problems associated with substance use and looking at problems associated with substance use over the past year. And there are a total of 11 criteria that we use when we're assessing the presence of a substance use disorder and the severity of a substance use disorder. And these are largely within categories of impaired control, social impairment, risky use, tolerance, and withdrawal. And one other thing to be thinking about as we think about a substance use disorder in youth is just that these criteria are not developmentally normalized for youth. And so they're the same criteria used for adolescents as for adults. And so, we do see differences sometimes in patterns of use among adolescents where they might be having significant problems related to their substance use, but maybe their pattern of use is more of a binge use pattern, and they don't have like a tolerance to a substance or kind of aren't having withdrawal symptoms if they stop using a substance, but are still again having significant problems related to substance use. So again, this is kind of the criteria we use to think about a substance use disorder. And when we look at patterns in substance use disorders, we also have positive news that there's an overall kind of been a downward kind of trend, kind of less of a kind of sharp trend as we look between 2021 and 2024 in comparison to the data that we looked at earlier around illicit drug use. But this is looking at the number of adolescents between the ages of 12 and 17 with a substance use disorder in the past year. And this is data from the National Survey of Drug Use and Health, which again is a national survey, and it's done more in the community as opposed to within schools. And so for kind of other age groups in terms of 18 to 25-year-olds and people 26 and older, there hasn't been a kind of decline from year to year as we look at kind of the percent of individuals with a substance use disorder, but do see a slight decline among adolescents. And so when I show the data around substance use and substance use disorders kind of within the overall general population to clinicians who work in a mental health setting, I often hear feedback, well, that's not what I see in my clinical practice. Like, are you sure that data is right? And so important to think about kind of that is what we see in the general population. But when we think about youth with a psychiatric disorder, these are youth who are at higher risk for substance use and at higher risk to develop a substance use disorder. And so this is data from meta-analysis that combined a lot of different studies to look at associations between having a childhood onset psychiatric disorder and your risk of developing a substance use disorder. And at the bottom, you see odds ratios. And so anything above 1 typically means someone's at increased odds of having a substance use disorder. And so you can see that if you have ADHD as a child, when you're comparing these kids with ADHD versus kids who do not have ADHD, children who had ADHD as a child are at 2.5 times greater risk to develop a substance use disorder. Kids with depression are at a little over 2 times greater risk to develop a substance use disorder in comparison to kids without depression. And then see a similar kind of pattern for oppositional defiant disorder or conduct disorder. Anxiety disorders, that wasn't a statistically significant increased risk, but that's also a very heterogeneous group of disorders. And we do know that conditions such as PTSD does increase someone's risk of having a substance use disorder. So something to keep in mind. And then we also know that substance use disorders are more common in adolescents with psychiatric disorders. And so this is data showing you the lifetime prevalence of a substance use disorder in adolescents with and without a psychiatric disorder. And those in the kind of green bars are the ones that have a psychiatric disorder, and blue are the ones without a psychiatric disorder. And so you can see that there's a much higher prevalence of both drug use disorders, which is largely cannabis use disorders, and alcohol use disorders among adolescents with a psychiatric illness in the green in comparison to adolescents who don't have a psychiatric disorder. And so again, with clinicians, who report like, hey, that kind of data from the general population doesn't really line up with what I'm seeing in my practice. Again, there's a reason for this, in that we know that kids with psychiatric disorders are at higher risk for having a substance use disorder. In kids with a substance use disorder, we just see a more kind of a higher prevalence of substance use disorders among kids with a psychiatric disorder. And so what about kind of receiving SUD treatment? And so as we look at the general population, do see that about 15% of adolescents who have a substance use disorder receive treatment. And, often hear, when kind of presenting that data from people that like, oh, well, these kids just don't come to care. They don't come to see their primary care doctor. They're not having touch points with the healthcare system. And, there's kind of important data that came out also from the National Survey of Drug Use and Health that did indicate that a lot of these kids, particularly kids with a co-occurring psychiatric disorder, are coming to treatment, and they are receiving treatment for their depression, but they're not receiving treatment for their co-occurring substance use disorder. And so this is looking between the years of 2011 and 2018 at the percentage of adolescents with a co-occurring major depressive episode and a substance use disorder. This is looking at the receipt of treatment. And that higher line that hovers around in 2019, about 42%, that indicates treatment for depression only. So around 42% of adolescents who had both depression and a substance use disorder in 2019 received treatment for their depression only. And very much kind of lower percentage receive treatment for both depression and their substance use disorder. That's that orange bar down below. And then the blue bar indicates youth who had depression and a substance use disorder who only received treatment for the substance use disorder. So these kids are kind of having touch points with care, and important that we identify them and provide them with support for both disorders. And as we think about kind of some of the reasons for low receipt of treatment among youth, both youth with a substance use disorder, with and without a co-occurring psychiatric disorder, it can be very difficult to find treatment, for either disorder for youth. We know that access to care is very challenging for children and adolescents with mental health conditions and behavioral health conditions. Sometimes an adolescent may not, want to come to treatment. It might be hard to motivate them to come to treatment. And hopefully Dr. Meisel's talk in April will help the audience with strategies to support parents in getting their adolescent to come to treatment. Stigma plays a big role in terms of as a barrier to receiving treatment. And then sometimes the substance use isn't identified as a problem and may not be perceived as a problem by the youth or their caregiver. And so, it's really hard to get treatment. So when you come to treatment, you're probably going to talk about the things that you feel like are a problem and not talk about the things that you don't think are a problem. And so that's important for us to be thinking about in the kind of where we're practicing. And so as we think about opportunities for prevention and preventing substance use disorders among youth with a psychiatric disorder, one thing that we can be doing in our practices is systematic screening. So trying to, identify youth who may have substance use that hasn't progressed to a substance use disorder, who are coming to behavioral health or coming to mental health treatment, and so be really systematically screening them. And then one other thing we can be doing is treating their mental health condition, and we'll talk about both these things in more detail. And so as we think about screening, I just want to kind of remind you and draw attention to two kind of validated screening tools for adolescent substance use that I personally think are fairly straightforward and a little bit easier to implement. And so one is Screening to Brief Intervention. The other is the Brief Screener for Tobacco, Alcohol, and Other Drugs. And for both these tools, they ask about substance use in the past year and really start by only asking about tobacco, alcohol, marijuana. And if a youth says no to those substances, then you're done. You don't need to ask any other questions. If they do endorse use of any of those three substances, then you do go on to ask about substance use for a couple other substances. But again, fairly kind of straightforward in that you're just really asking about use in the past year for different substances. And then based on their use in the past year, the frequency of use, that kind of categorizes youth as kind of at higher or lower risk for a substance use disorder. And so the S2BI looks at kind of frequency in terms of never, once or twice, monthly, weekly, or more. And then the BSTAD asks about how many days in the past year. And again, based on a use response, they're categorized at kind of no risk, lower risk, or higher risk for having a substance use disorder.
Dr. Yule, quick question. Are those tools free to the public?
Great question. Those are free to the public, and they're also via NIDA. They do have a way that you could use this kind of electronically. It's not kind of built out in a way that you can kind of integrate it into an electronic health record. But if you do have like a tablet in your office and you have a youth coming in, they can do this on paper. It's either self-report or clinician administered. And you can also pull up this NIDA website that just kind of walks the youth through the questions and then provides feedback about their risk level. And so if you have someone coming into your office and you have a tablet that you could kind of hand them that's kind of pulled up to that website, you could be doing the kind of many other things that you often need to do as a part of an appointment while a youth completes that screener to kind of help with integrating this into your practice. So again, they're free, and there's an electronic there's a mechanism to do this electronically, free also as well through NIDA.
Great, thanks.
Great question. So as we think about kind of another opportunity for potentially preventing substance use disorders among youth with a mental health condition, one question that comes up is, does treatment for a mental health condition prevent a substance use disorder? And I think as clinicians, we hope that the treatment does, kind of decrease risk for other conditions. But we really don't have a ton of research or as much research as I would like to see in this area. And so a few years ago, we did do a systematic review looking at pharmacologic treatments of psychiatric disorders among youth and, looking to identify studies that looked at kind of whether or not treatment had an impact on later risk for substance use disorder. And most of the studies that we identified have been done with ADHD, and then a smaller number with depression and bipolar disorder and psychotic disorders. And for ADHD, the data is a little bit mixed, and that some research has shown that there's a decreased risk associated with ADHD treatment. Some other research has shown that there is no kind of change in risk associated with treatment. But one thing that's has emerged from that research as well is that the timing of treatment matters. And so for ADHD, if you initiate treatment early and have more consistent treatment over a child's lifetime, then they're at decreased risk for substance use disorder. And so again, we have, more data around ADHD and the role of treating ADHD and later risk of a substance use disorder, less for other conditions. And, the couple of studies that we did identify for depression showed decreased risk. For bipolar disorder, the data was mixed, and that treating with a mood stabilizer like lithium did decrease risk of a later substance use disorder, but other psychotropic medications such as antidepressants were associated with having an increased risk of a substance use disorder. And so one challenge is that you can't really do a randomized control trial where you randomize kids to not receiving mental health treatment if they're struggling with functional impairment related to their mental health condition. And so we've been curious about this research question, and so did try to use quasi-experimental methods to look at specifically mood disorders and the role of treating mood disorders and later risk for substance use disorder, and used a large data set from the Mass General Brigham Hospital System and looked at youth ages 16 to 30 years of age who had been diagnosed with either depression or bipolar disorder and did not have a past or current substance use disorder. And then kind of looked at how they did over time, and used propensity score matching to compare those who received treatment to those who did not receive treatment. And when we looked at treatment, did look at medication treatment and therapy. And what we found was that treatment in and of itself didn't change later risk for substance use disorder in youth that were kind of using data from the electronic health record. And so with this analysis, we looked at hazard ratios. And so above 1, where the confidence interval doesn't cross 1, would indicate that there is a kind of decreased risk associated with treatment. And so as you can see that for looking at treatment for major depressive disorder, the hazard ratio was just a little bit above 1 of 1.06, but the confidence interval crossed 1. And so there was, again, no statistically significant difference in terms of later risk for substance use disorder between youth who received or did not receive treatment for depression, and kind of saw a similar result for bipolar disorder. But when we did look at timing, again, kind of got into a little bit more of the details about this, we did see that longer duration of treatment was associated with the decreased risk for substance use disorder. And so for both depression and bipolar disorder, saw that there was approximately a 2% risk reduction for each additional cumulative month of treatment. And so I think one thing we often are kind of struggling with clinically is how long to continue treatment for youth who have stabilized. And so this data does suggest that potentially longer might be better in terms of thinking about substance use disorder risk later in life. So we overall kind of need more data in terms of thinking about what is, how does mental health treatment impact later substance use disorder risk, and hope to have more findings in this area soon. So, in a perfect world, we've prevented the onset of substance use in adolescence, and then we've prevented a substance use disorder. But if we haven't done that, one thing that we want to be thinking about is decreasing risk associated with use. And so now I'm going to kind of shift gears and talk about adverse events associated with substance use in youth and strategies to try to mitigate risk if someone's using substances. And so as we think about adverse effects, I think it can be helpful to ask broadly about adverse effects related to substance use. One thing as we think about youth is that, we do have a lot of medical terminology that we use in substance use disorder treatment. And if you kind of think about it, the term overdose is a medical term, and have found in doing community work in terms of education around overdose risk that a lot of youth in the community don't necessarily have the same definition of overdose that I might. And so have found it's helpful to use this broader term to make sure that I'm getting kind of an accurate report of someone's past history of having problems related to substance use. And so this is a definition that was developed by colleagues at the University of Michigan that I use clinically. So have you ever taken more drugs, alcohol, and/or medications than your body could handle? And so that's very descriptive. Might pick up things that are not clinically significant, but I think you're not going to miss kind of a clinically significant event that may have occurred in someone's past history if you ask this broader question. Then as we think about opiates more specifically, do want to highlight that we have seen a disproportionate increase in drug overdose deaths among adolescents. And, kind of it has declined over the past couple of years, but between 2019 and 2020, saw an increase in adolescent overdose deaths by about 90%, which was relative to the increase in the general population of around 20%. And so when we looked more closely at the data, do see that these drug overdose deaths, similar to adults, have really been driven by exposure to illicit fentanyl. And so this is a graph showing you deaths per 100,000 among adolescents specifically by substance between 2010 and 2021. In that line that's shooting up are illicit fentanyls and synthetics. And then the orange line are benzodiazepines, the blue line are methamphetamines, and that open circle is cocaine. But you do see that kind of prescription opiates and heroin are down below. And so again, really this kind of big increase, which is similar to adult populations, but has been kind of disproportionately seen among adolescents, is kind of this increase in overdose deaths due to illicit fentanyl. And as we think about kind of exposure for youth in terms of their exposure to illicit fentanyl, it's largely been through counterfeit pills. And so this is a picture showing you a counterfeit pill in comparison to a pill that was manufactured by a pharmaceutical company. And you can see it's kind of hard to tell the difference. And maybe if you're a pharmacist, you could tell the difference. But especially an adolescent who's kind of getting this, via social media or kind of from a friend, they're probably unlikely to identify that they're getting a counterfeit pill versus a pill that was manufactured by a pharmaceutical company. And really there's just been an explosion of these counterfeit pills. And so, when I talked, and this is showing you a figure of just the number of pills containing fentanyl that's been seized by law enforcement between 2017 and 2023. And so in 2023, there were 115 million pills that contained illicitly manufactured fentanyl. 115 million counterfeit pills seized by the DEA. So that's just like a ton. And so when I talk to youth, I often kind of tell them, unless you go in the pharmacy with your friend and see the pharmacist hand your friend a bottle of pills, it's very likely, kind of more likely than not that potentially what you think you might be getting from a friend or from someone else is not a kind of a pill that's been kind of distributed or kind of manufactured by a pharmaceutical company. It's most likely this kind of counterfeit pill that could have like who knows what in it, but there's a high likelihood that there might be fentanyl in it. And so again, what we see is that sometimes youth will think that they're using Adderall or Xanax or benzodiazepine, but actually they're using a pill that has fentanyl. These might be youth that have never used opiates and have no tolerance to opiates. And so that is what kind of puts them at higher risk for an overdose. And this is also played out in the data in that many of the youth who died by overdose between 2019 and 2021 had no known history of opiate use. So 65% had no known history of opiate use, yet had a kind of an overdose death related to exposure to opiates. And as we think about opportunities for prevention, 41% of these youth who died by drug overdose between 2019 and 2021 had a history of a mental health diagnosis. And then, so 41% of these youth who died of a drug overdose had a mental health diagnosis in the past, and then around 20% had a history of mental health or substance use disorder treatment. And so, with this data and kind of this change in kind of the epidemiology around overdose among adolescents, have really shifted to thinking about universal overdose prevention, and really trying to educate all youth that are coming into treatment, especially in a psychiatric clinic, especially in a substance use disorder clinic, providing them with information about how to recognize an overdose, how to respond to an overdose, and then risk factors for an overdose. And it can be hard when someone's first coming into treatment to talk to them about kind of risk of death, or talk to parents about their child's risk of death. And so have worked to kind of develop language that really normalizes this and kind of present and talk about this as we really are kind of talking to kind of all kids and families about how the drug supply has changed over the past few years, and want to make sure that you have this information. And again, it can be hard to kind of introduce this language into a clinical encounter when that's not something that's on a youth or family's mind. And so do want to highlight language that's provided in this article that was led by Scott Hadland, that provides like really kind of language you can just copy and paste in a way into kind of things that you're saying with families around how to initiate the conversation, what type of education is important to share, and kind of how to language really that kind of walks you through incorporating this into your clinical practice. So now I'm going to shift gears and talk a little bit about cannabis as well, since we have seen with cannabis commercialization, both in the US and elsewhere, that there's really been an increase in different types of products of cannabis, and that these kind of newer products have a really high THC concentration. And so this is showing you pictures of different types of cannabis products, and then the kind of amount of THC that they have in them. And you can see that kind of the plant back in the 80s, just had like a THC level of 3%. And then in 2017, that's up to 17%. And then there's these newer products like hash oil and dabs that they can have up to 80 to 90% THC content. And the hash oil is kind of what people are often, kids are often vaping, and kids do lean towards these kind of other types of cannabis products because when they vape cannabis, they don't smell like cannabis, and they can kind of very kind of quickly use the product, get pretty high pretty quickly, and then kind of put it away. And so this has become a big problem with these devices in schools and in other places, because kids are kind of using, it's hard to kind of tell that someone's potentially using cannabis. And why this matters is that as we have an increase in the THC content, there's an increased risk for adverse events associated with cannabis. And this is also played out in the data. And so this is data from Canada, looking at hospitalizations related to cannabis, but before commercial, pre-legalization and then since commercialization. And you can see that this is looking at the rate ratio. So similar to an odds ratio or an hazard ratio, anything above 1 means that there's kind of an increase. And so with commercialization, there's been an increase in hospitalizations for cannabis-induced psychosis, hospitalizations for cannabis withdrawal, and then a little bit of a less of an increase for also poisonings and acute intoxication related to cannabis. And, likely related to that people are using a different product now than they were pre-legalization. And this, kind of, especially for youth, are using a product that has a much, much higher THC concentration. And so then kind of they're at increased risk for these adverse events associated with cannabis. And so do want to draw your attention to cannabis, the kind of phenomenon of cannabis withdrawal, particularly for people who are working in a mental health setting, because several of the symptoms of cannabis withdrawal are mental health symptoms. And so cannabis withdrawal is something that can occur kind of more kind of developing a tolerance to cannabis and kind of dependence on cannabis, a physiologic dependence on cannabis, can occur more quickly if you're using a more potent cannabis product with a higher THC concentration. And so cannabis withdrawal was described and kind of included within the DSM-5 and is defined as having 3 or more symptoms that develop within 1 week of suddenly stopping cannabis use. And so this is something that we see with people who are using cannabis regularly. So you have to kind of have developed a tolerance and to then have withdrawal. But do see kind of pretty pronounced irritability and anger associated with kind of suddenly stopping cannabis. And parents will describe this as, maybe their teenager was like grouchy or grumpy, but then when they kind of suddenly stopped the cannabis, they were, slamming doors or punching holes in walls, like a really notable and marked increase in irritability and anger. Can also see anxiety, depressed mood, insomnia. And it's important to be aware of the phenomenon of cannabis withdrawal, especially working in a psychiatric setting. And then I'll often talk to kids and they'll tell me like cannabis really helps me fall asleep. And I'll kind of say like, well, how do you know that it helps you with falling asleep? And they'll say, well, if I don't use it, I can't fall asleep. And then I'll kind of, we'll think with them about like, well, maybe it's helping with your sleep, but one thing that can also be also at play is that you might be having cannabis withdrawal. And then we also know that that youth with cannabis-induced psychosis are at high risk to develop a persistent psychiatric disorder. And so again, did see really kind of clearly in Canada this increase in the kind of instances of cannabis-induced psychosis leading to hospitalization in this era of commercialization. And it's important to kind of know that nearly 50% of individuals with cannabis-induced psychosis do go on to develop schizophrenia or bipolar disorder. And typically this is happening within 2 to 3 years of presenting with cannabis-induced psychosis. And we know that individuals who are late adolescents, young adults, are at the highest risk to convert from cannabis-induced psychosis to schizophrenia. And then lastly, the kind of third big kind of adverse event associated with cannabis is cannabis hyperemesis syndrome. And this is also can be counterintuitive for youth and families in that, cannabis can help with chemotherapy associated nausea. But when it's used heavily among youth, have seen this other phenomenon happen, which is cannabis hyperemesis syndrome, where if someone's using heavily, can have this episode of hyperemesis where kind of suddenly they develop really significant nausea, vomiting, and the only thing that really helps to stop the nausea and vomiting is a hot shower. And often these kids are presenting to emergency rooms and sometimes being hospitalized because the symptoms are so severe. And then when they're really sick, they stop their cannabis use. And so over time, their kind of level of cannabis goes down and then they start to feel better. So then they go back to using cannabis and this thing kind of, the cycle happens again. And so just one thing I think that, again, we're seeing kind of more commonly with kids with heavy cannabis use is either lower levels of persistent nausea or this kind of more severe kind of manifestation of this phenomenon, which is the cannabis hyperemesis syndrome. So what can we do to decrease risk associated with cannabis for youth? We can try to kind of get them to use a lower potency THC product. And so we'll talk to kids about one, I'll provide education that helps them better understand what the difference is between the plant and these other products. They often know that there is a difference. They feel different, but they're not, they're less aware of that the difference is related to the THC content. And so we'll try to get them to shift to lower potency THC concentration. Another strategy is trying to shift cannabis products to have less THC and a higher cannabidiol content. But one thing to be aware of is if someone is primarily using cannabidiol or kind of in larger quantities, especially, it's important to monitor their liver function just because some clinical trials that have been done with cannabidiol have seen an increase in kind of liver enzymes associated with taking cannabidiol consistently. And then if someone shifts from potentially vaping cannabis or the plant to edibles, just for them to be aware of the delayed onset of action, that they're kind of not going to have that kind of quick high, that it's going to be delayed, and because we don't want them to kind of just keep eating edibles, looking to have that same kind of immediate effect and then have this delayed exposure to a large quantity of cannabis. And then if youth are experiencing problems related to their cannabis use and they're ready to decrease or stop, thinking about medications to try to mitigate cannabis withdrawal symptoms. All right, so we're going to shift in this last 10 minutes to the last part of the talk and really focus on treating co-occurring psychiatric disorders and substance use disorders in youth. And so again, kind of talked about, hopefully we can prevent a substance use disorder among youth with a psychiatric condition. If they're using substances, hopefully we can mitigate risk. And now if they have the kind of the full substance use disorder and a psychiatric disorder, how do we think about treatment? And so really want to promote this idea that there's no wrong door when you're treating co-occurring disorders. And it's important to support youth with a substance use disorder and their caregivers wherever they're presenting for care. So excited to see so many people here for this talk because hopefully you feel like a little bit better prepared to support kids if you're in a mental health, primarily a mental health setting, more prepared to support kids with both disorders. And really the standard of care is integrated treatment for both disorders, ideally with the same clinician addressing both. But if that's not feasible, then trying to partner with someone who maybe has more substance use disorder expertise to both learn from them as part of co-treating and then to make sure that a kid has treatment for both. But it's kind of which I alluded to in that comment, that sometimes it can be hard or people may feel less prepared to treat both. It can be hard to find integrated treatment. As we think about medication more specifically, some of the kind of general principles when treating co-occurring psychiatric disorders and a substance use disorder is to consider medications to treat both disorders. And so often medications for substance use disorder aren't necessarily discussed with adolescents and young adults for many different reasons, but important for youth and their families to know that we do have medications for substance use disorders if that's of interest, particularly if youth are having severe impairment related to their substance use disorder. Really important to emphasize adherence, consistent adherence, and then youth kind of, it takes a while to kind of get on track with consistent adherence. And so it can be helpful to have frequent follow-up, kind of prescribe smaller quantities of medication, especially if you're concerned that someone's maybe not taking it as prescribed or taking more than prescribed. And then be mindful of the interaction between the medication and the substances. And so, particularly mindful if you're prescribing medications that are sedating and someone's using a sedating substance like alcohol or opiates, what might happen if they took that medication and also were using substances. So, and then as we think about kind of medication trials for youth with a substance use disorder, I think this is one of the reasons why potentially people talk about medications less with youth. medications for substance use disorder, just in that we don't have as much data in comparison to adults. There's one FDA-approved medication for treating substance use disorders among youth, and that's buprenorphine naloxone for youth with an opiate use disorder, moderate or severe. But there are, have been a handful of promising studies for other substance use disorders, including alcohol, cannabis, and tobacco or nicotine. Similar to kind of other areas, especially in child psychiatry, where we may have less kind of data from randomized controlled trials, we're sometimes in a situation where we may be prescribing off-label or prescribing something that's not FDA approved for the condition that we're prescribing it. And so really thinking and having individualized conversations with kids and families about what we do know, what we don't know, thinking about the risks and benefits and kind of what makes sense for the child that you're working with. As we think about a couple of specific co-occurring disorders and think about attention deficit hyperactivity disorder more specifically, general clinical recommendations in treating kind of both ADHD and a substance use disorder. If someone does have lower level substance use, do recommend continuing to treat ADHD, with a stimulant or a non-stimulant. And then if someone has a more severe substance use disorder, can be important to address the substance use disorder first, because if they're having a lot of impairment related to the substance use, their kind of concentration and attention difficulties might be related to substance intoxication or withdrawal. And so can be helpful to see that stabilizing a bit before initiating or continuing treatment for the ADHD. But kind of once they're starting to stabilize, then thinking about extended release stimulants or non-stimulants. And when I say a more severe substance use disorder, I mean, kids who are using kind of cannabis like all day, every day, do consider kind of lower level substance use around cannabis to be maybe like once a day or a few times a week. And then more severe substance use disorders, including if someone is having kind of frequent opiate use or might be having intoxication related to their opiate use or opiate withdrawal symptoms. That would be, again, kind of situations in which would want to try to stabilize the substance use disorder first before initiating treatment for the ADHD. And then if you are using stimulant medication, if possible, trying to involve a support person to help with monitoring adherence. And then, again, frequent follow-ups to monitor adherence and response. And at every visit, kind of checking in around, hey, like how many days over the past week did you take the medication? Kind of any urges or thoughts about not taking the medications prescribed or doubling the dose, or, really just kind of asking kind of in as much of a non-judgmental way as possible to kind of make sure that someone's taking the medication as prescribed and they're not running into problems related to the stimulant medication. As we think about co-occurring depression and substance use disorders, there's been a handful of studies looking at the effect of antidepressants for people with both depression, for adolescents with depression and a substance use disorder. One challenge with these studies, I think, is that the dose of the medications have been definitely conservative. And then both groups of participants in the studies, people who received the active medication and placebo, all received therapy. And so in a lot of these studies, didn't see a significant difference in both substance use and depressive symptoms between those who received the medication and did not receive the medication. But when they did put this all together in a meta-analysis, did see that this is kind of showing you the risk ratio. And so above 1 is kind of showing favors medication. And this is looking at depressive symptoms, and did see that kind of treating with an antidepressant for someone who has depression and a substance use disorder, or for adolescents in particular, was associated with a decrease in depressive symptoms when all these studies were combined, but didn't see a difference between medication and no medication for the substance use. And so antidepressant medication may be helpful for symptoms of depression, but potentially less impactful on in adolescent substance use. And then lastly, as we think about co-occurring serious mental illness and substance use disorders, there's been two randomized controlled trials for bipolar disorder, looking at youth who have symptoms of bipolar disorder and a substance use disorder, one with lithium and one with topiramate. And for both these studies, active treatment, so treatment with lithium and treatment with topiramate, when compared to placebo, was associated with improvement in substance use and functioning, but no difference in mood changes between active treatment and placebo. And as we think about general clinical guidance for this patient population, both youth with bipolar disorder and psychosis typically are recommending treating both with medication, regardless of the severity of the co-occurring substance use, but do need to be mindful of medication substance interactions and risks associated with inconsistent medication adherence, especially when using mood stabilizers with a narrow therapeutic index, such as lithium. And so typically, I will shy away from kind of using lithium for someone who has an unstable substance use disorder and bipolar disorder, just because of concerns around non-adherence and kind of substance use in that narrow therapeutic window where someone might experience negative effects related to the medication if they get dehydrated and kind of may be less consistent with following up with lab draws that are needed if you're on that medication. So again, something to be mindful of. So, and then I think general considerations in treatment, important to stay patient and family centered, and the overall goal is to get them to come back. And so really engaging them around their concerns. So if they're coming with concerns about their substance use and they have a co-occurring psychiatric disorder, but really just want to talk about the substance use, then that's where I'll kind of stay. I'll kind of raise concern about wanting to also address the co-occurring psychiatric disorder, but kind of again, stay focused on where they're at. Likewise, if they come in and are really just focused on the psychiatric symptoms and kind of less ready to acknowledge a co-occurring substance use disorder, I'll work to engage them in treatment for their psychiatric disorder, but still be monitoring and bringing up the substance use as we're progressing in treatment. And then to remember also that youth and their caregivers can have waxing and waning motivation to change. And so to not be disappointed or pessimistic if 1 week you work with a youth and they're like really ready to make a change and this is going to be the week, and then the next week they're kind of in a place where they're not ready to change their substance use patterns, to stay optimistic. The key part is they came back to treatment, and that's the overall goal initially as part of engaging this population in care. So in summary, psychiatric disorders and substance use disorders commonly co-occur in youth, and we do need to continue to improve our understanding of the relationship between these two disorders to identify additional opportunities for prevention, strategies to decrease risk associated with substance use, and then improve treatment outcomes when people do have both disorders. And so with that, I'm going to stop sharing, and Zoe will put up the survey for the evaluation. And we would love your feedback and would also love questions. So
great. Thank you, Dr. Yule. We did have several questions that I will try my best to moderate. So one person asked, as you were reviewing different brief assessments for substance use in psychiatric populations, somebody asked if you're aware of any assessments that are adapted, that have cultural adaptations for specific subgroups of individuals.
That is a great question. I'm not aware of any adaptations I can think of for youth. I don't know, Brandon, if you know of some. I think the substance use one is pretty straightforward, and I don't know if it's been looked at in terms of its validity across different cultural groups, but I think that would be important to be thinking about, and something for further research. It's a great point.
Great. Somebody also asked if you were talking about overdose among youth and the increases therein. Somebody asked if you're aware of schools. Do schools carry or have naloxone / Narcan on hand? Are you aware of anything like that?
Yeah, that's a great question as well. And so there has been legislation trying to advance and increase access to naloxone in schools. Because one challenge is like potentially like the nurse can have naloxone, but really we want like everyone in school to have naloxone. And so I think that there's been in some school, I don't remember the details of it, but that one issue has been maybe the nurse has it, but it's not kind of widely accessible across kind of a school in terms of other people in the school building having access to naloxone or consistently carrying it. But I think in Massachusetts, they've been working on legislation to change that, to really try to encourage and promote naloxone access for everyone, for all
Thank
kind
you.
of all adults in the building and kids too. But
Yeah, we've had some comments that say some schools have it in their first aid kit, and they recommend putting it with other kinds of medical devices. Yeah.
and
Um,
it will just one
no, no,
quick
no.
comment
Go
along
go
this.
ahead. Go ahead.
Yeah, no, along those lines is did run into this like concern in doing an IRB or in kind of doing research in this area of people being worried about giving adolescents naloxone and like what are the different risks. And so there was a nice paper published really showing that there's been an increase in pediatricians prescribing naloxone, and so that this is being done by pediatricians. And so like
Nice.
kids are accessing naloxone. Adolescents and kind of younger kids can go into a pharmacy and get it over the counter, although the cost is often prohibitive. So just because they're little doesn't mean they're not at risk. And just want to emphasize that naloxone is a very safe medication with no risk for misuse. And if you give it to somebody who does not have an opiate overdose, nothing bad will happen.
Thank you. And speaking of states and different state laws, somebody asked, they were just wondering around state laws with respect to treatment, being able to consent to treatment, where some states, go pretty low in age for youth to be able to consent to treatment on their own without a parent consenting to treatment on their behalf, and some would when where any youth could do it. Are you what do you have to say in general around differences in treatment access there? Any comments you have on that?
Yeah, it's a great question. I would say that it's really important to know your state law. So, like, to kind of know what the law is in the state that you're practicing in. And I think that there was a paper published a couple of years ago that really looked at kind of laws for kids and consent around kind of mental health care, treatment for a substance use disorder, reproductive health care. But it varies like among all these three different categories, state by state, which is tricky.
Thanks. And then one last question before we wrap up. Where really it's a sort of there are two questions both related to um, elements that might put youth at increased risk for substance use. So somebody asked generally about if you've seen a correlation in your practice or in the research around self-esteem and lower levels of self-esteem and increased risk for substance use, separate from maybe the presence or absence of a psychiatric disorder.
Yeah, that's a great question. I'm less familiar with the literature in that area, but I think if someone has kind of a lower self-esteem, they might seek out kind of peer groups or be looking for peer acceptance and kind of then end up with a peer group that's using substances and potentially kind of be at higher risk to use substances. So that's one thought I have, but I'm less aware of kind of research in that area, but it's a great question. But
And then one final question, and then we'll wrap up. And then as just a reminder to everybody, we are going to send out both the recording and the slides. So if you have questions about what was in a slide or specifically what Dr. Yule said about this or that, that will all be available after the talk. But one final question folks had around parents, and if you're familiar with anything around parents' use of substances and potentially increasing risk for their child's risk of substance use.
Yes, and that's a great question as well. We do know that kind of right, that risk for substance use disorder is highly heritable, and so that's kind of 50% of your kind of risk. And then kind of modeling can influence substance use patterns among kind of youth. And so if a parent potentially is modeling that it's okay to be using substances, and particularly like having problems related to their substance use, that is associated with, I think, increased risk. And then I think one thing we often see, right, with kids getting into treatment is parents might be like, but I use like cannabis for a different reason to help with my pain, and in kind of in that nuance between you might be, as an adult, using your kind of, as an adult, your risk of developing a substance use disorder is different, and you might be using it in a very different way. And so as we think about kind of supporting for your child, like how do we talk about that? And as clinicians, really trying to support conversation around that with the goal of having people come back to see you. So, because I think there's a lot of judgment, and then especially parents experience a lot of judgment from clinicians. And so us all being kind of mindful of like, this might be different for the parent than the kid, and how do we kind of think about that and navigate that? But
Yeah. Great. Well, there's lots of thank yous, Dr. Yule, in the chat for you, and how informative the talk was. And so thank you for your time very much. And I'm going to just share this final slide for folks before we go. Please, we have a post-webinar feedback survey we'd like you to fill out. Your feedback is really important and provides support for this type of work to continue. Just scan this QR code to access the SAMHSA feedback survey. The survey will ask about your satisfaction with the training program you just completed, some basic demographic information. Your responses will help the ORN improve the services they provide. Thank you in advance, and thank you everybody for being here, and special thank you to Dr. Yule, of course. Thanks everybody. Have a great rest of your day.
Honored to be here. Thanks, you guys. You were an amazing audience. Great questions. So
thank you.
Thank you.